inspection manager with the Care Quality Commission from 2012 to 2023. I retired on the 31st of March this year from that role. And part of my role within CQC, as well as being an inspection manager, was an enforcement lead. And I also managed a team of inspectors who were particularly looking at the criminal side of CQC's prosecution powers. And I'll cover a little bit more about that later on. Okay, nice. And I've got a bit more on these slides. So.
Okay, thank you very much. Thank you. So my name is Nyson. Some of you might have been in touch with me or have some contact with me. So my background, I'm an adult social care inspector. I was an adult social care inspector from 2015 until last year. So I worked mainly in the Northwest care homes, domiciliary care agencies, undertaking inspections for both service types of services. As part of that remit as well, I was wearing the enforcement lead hat for the Northwest. And as part of that role, I found myself in the tribunal a few times. So when enforcement takes us to tribunal, I had a few cases that I had to go to tribunal with. I also found myself doing a few enforcement, criminal enforcement cases, some of which have been in the news, some of which have now been concluded by CQC. So I've got a varied experience from the lowest level of enforcement, which is, the recommendation to the warning notice, to the tribunal, and, going to the magistrates. So, the warning notices and the notice of decisions have worked along those lines. So what we are doing now is we provide some support for providers, consultants, coaching, and so on and so forth, with varied consultants with different experiences, including myself. One of them, Sorai, is here with us. So we work alongside each other to just provide any support around turnaround, or just coaching and developing awareness on the regulatory framework. So the idea really today is myself and Dave, we did ask people what they wanted, in terms of support, anything that they would want, along the lines of, awareness on the regulatory support. And people said they wanted someone with a background of managing enforcement at a higher level, which is Dave, that you've got, and someone with the background of inspecting in terms of the day-to-day inspections, knocking on the doors of providers, which is myself, really. So kind of like doing a double act, myself and Dave. So the idea is we're trying to introduce, some awareness on risk management and the likely consequences of not managing risk effectively, really. So we'll be looking at individual harm and regulatory, and the consequences of regulation, regulatory consequences. Dave will cover that. CQC enforcement powers for registered person. I think the main thing is to try and help registered managers and providers, in particular registered managers, because they get left behind. Because providers are companies, usually they are limited companies, they are protected, but registered managers sometimes don't understand their registration is independent, and when enforcement comes in, especially criminal enforcement, it's directly on the registered manager if they are liable. So Dave will provide you some of the information on the likely pitfalls and what you need to ensure you are doing to protect yourself from the likelihood of enforcement action. Okay. So in terms of our objectives, it is what I've just said there. We've got the principles of risk management, what inspectors are looking for, the areas that they are looking for. These are bite-sized. We won't be giving you enough detail because you need a whole week to cover risk management. So we won't be going in that much detail. We will give you enough to stimulate your thought process and the reflection around what your processes are right now, or in what you may need to put in place. So it's just there to ask you some questions so you can start thinking about what to put in place. So by the end of the session, really what we want is you need to have an idea of what risk management is and the principles, but saying that we are not going to teach you to suck eggs. Whatever you know already, we know every care home carries a risk. So you are carrying a risk every day. We won't be telling you that you've got risk within your service, because we know everybody's got risk. We also want to provide you an idea of what risk management and monitoring principles are, awareness of possible actions and awareness of CQC enforcement action on registered managers. So I will be short and sweet. So just to start with, in terms of risk, what do we mean by risk? Is anything that is likely to cause harm or to cause discomfort to anybody. That becomes a risk. So like I just said, every care home, because we care for people who are vulnerable or people who've got some ailments or multiple comorbidities, we carry a risk. Just by the mere fact of opening a care home, you are carrying a risk. So the idea is we want to, within a care home, you're already opening with a risk. So the idea is, the first principle is, can you identify what that risk is? Okay, in terms of regulatory risk, in terms of risk to the individuals that you're looking after, at any given point, are you able to identify what the risk is? Once you've identified the risk, these are the principles that you can actually put in place to walk through. Once you identify the risk, or is it at an individual level or at an institutional level, you identify it, but then you want to assess that risk and identify what is the impact of that risk, what is the likelihood of that risk happening. If it's high risk and there's a likely chance that someone will get hurt, if it's at an individual level, you want then to put the control measures for that individual. If it's at an institutional level, you'll be looking at the measures that you can put within the home or within your service, if it's a DCA, to monitor and reduce that risk. Okay. I use the word reduce because some risks we can reduce, some risks we can remove, but not all risks can be removed. So we need to be clear about that. When you're managing risk, if you aim to remove risk, you're likely taking that medical approach, which is to treat. Half the time we can't remove risk, or our aim is to try and control and minimize the risk. So that's what you're looking for. You identify it, you assess it, you put the control measures. Once you put the control measure, this is where your documentation come in. For each identified risk, you need to have the control measures will be your care plan. Okay, your care plan will stipulate, supported by that risk assessment, will stipulate exactly what are you doing on a day-to-day basis. What are you expecting your care staff or your personnel to do to minimize the risk on an individual, at an individual level. You record your findings, then you review those control measures on a monthly basis. So if I give an example of if the risk that I have is that I'm likely to lose weight unintentionally because of my nutritional risks, or because I don't eat and drink enough, at the end of the month, you are expected to measure, where am I in terms of that risk? So what do? This is where, if you've got your MASH2s, anybody who's measured the MASH2, 2 to 5, 2 to 4, is supposed to be weighed. The recommendation, you weigh them on a monthly basis. If you decide your care plan is saying we weigh them on a weekly basis, that's your control. In addition to that, you've got the risk reduction measures that are probably the actual support that you provide to that person to reduce the risk of losing weight, which is probably making sure they are eating enough, encouraging them to eat more, or probably encouraging, fortifying their food. So all those measures, they are your control measures. So when you are looking at risk, it's about looking at all those steps. Are they evident within your care plan with each individual, or with each risk area? It could be risk around fire or falls. do we have? Can you clearly identify the risk and the measures that you've got in place? And can you clearly evidence that you're reviewing the control measures that you have in place on monthly, or when there is a change? It doesn't have to be monthly. When there is a significant change in that individual's needs, there is a likelihood that the risk itself will increase. So those are the principles that we work with, and you can ask yourself whether the individuals or your organization is actually following that. If you were to do that, the likely chance of you meeting the needs around risk management is high. Okay. So the law itself requires you to identify what causes injury or what causes hazards within the organizations. There is a requirement within the law. So you've got the Health and Safety at Work Regulations 1999, because you're an employer. In the majority of the times, as a provider, you are an employer. As a registered manager, you may be employing people. So that's the first law that holds you to account in terms of risk management. There is also the Health and Social Care Act, which Regulation 12 itself, 12.1, requires you to ensure that you're identifying risk and you're monitoring it, you're putting measures in place to monitor that. But what you need to demonstrate in terms of Regulation 12 and any other regulations linked with managing risk, you can think of Regulation 13, which is safeguarding. You can think of Regulation 14, which is nutrition. What you need to think about is, are you doing everything that's reasonably practicable to provide safe care and treatment? So that's what the law says. So that's the bit where most providers get caught out, because are you doing everything that is possible? So if we go back to the principles that we talked about, if you have identified that risk, if you've got measures in place and controls in place, and you're reviewing that, it is possible that you are meeting that threshold for doing what's reasonable, what's practicable to a lay person in the street, to say people's risk is being managed. So that's what the law says there. There's a definition here, in terms of, you're not expected to eliminate all the risk, but you need to do everything reasonable. And that's the term that you will find if you find yourself in the wrong side of regulation. That term will be thrown around to say, as a registered manager or as a provider, what did you do? What did you say? Someone was falling and they were on the third floor, where there's limited, oversight on that person. Something practicable will be to bring that person downstairs or to a bedroom which is next to the nurse station. That's practicable. You can actually use that as evidence to say, I did what's practicable to monitor the risk around that person. It could be that, best practice, nice guidance say this person needs to be weighed monthly, but we thought the risk was high. We decided we're going to weigh them on a weekly basis. It's a practicable measure that, you would have taken. If you were to provide that, that's evidence of you doing all that is possible and that's practicable to manage and reduce risk. Okay. So inspectors are looking at how are you managing risk associated with people's health needs. So we're talking about all the comorbidities that we know people bring with them when they join your care home. So it could be things linked to their health. So skin, diabetes, wounds, infections, constipation, anything that's linked to that individual's health. Inspectors are looking at how you're managing that. So you need to identify, as a good service, you need to have an idea of what risks are we carrying, what health needs do people have, and what risks are associated with that. Then you also have the risk of receiving care. There's a difference there. The risk of receiving care is the risks associated to the actions that you as the provider and your staff need to do when people are receiving care. So I'll give an example. When you are hoisting, someone requires to be hoisted to sit on the toilet. Someone requires your actions so that their needs can be met. Thus, risks associated with receiving care. Or bathing someone, going for a shower. it's risk associated with receiving care. So those are the areas that, you can talk about in terms of what have you done yourself to ensure that, for example, if someone requires a hoist that is serviced and in good working order, then you have managed the risk associated with hoisting. So you've got also the risk associated with equipment. That's to do with your premises, all the premises, all the equipment that you use within that service. They pose a risk, and they are your responsibility to ensure that the risk that they pose to people is minimized, and you've got controls, and you actually know what the risk is. So those are areas that, the 3 areas, they are not exhaustive, but I'm just trying to entice and just say to you, these are some of the key areas that you actually need to be aware of. What are the risks with my staff when they provide care? Say, when they're moving people from A to B, that's receiving care. But with each individual, when they come in my home, their ailments, their illnesses, their needs, they are a risk, then obviously the property itself. So those are some of the things that you need to think about when you're thinking about what inspectors are looking for. These are the particular areas that they are looking for. How are you managing these areas? Okay. Potentially, you may fail to either identify the risk or to manage it. There's a lot of risk that carries that. There's a likelihood that you will be in breach of regulation. There's a likelihood that your service will be rated, say, inadequate or requires improvement. If you can't manage risk, you can't be good. There's a likelihood that the governance systems within the home will be determined to be inadequate. And there's a likely chance that you will face enforcement, which is probably civil or criminal action. And the chances of that are high if you don't have the principles that we talked about and the evidence to actually demonstrate that you are doing all that is possible to manage and reduce risk, which might include identifying the risk, training your staff, or having a policy in place and reviewing those policies on a regular basis. So those are the areas that I think you are likely to be caught out. But in terms of, let's say you then end up in the wrong side of the law, I think Dave will probably be the one to tell you now what happens, what are the likely things that can happen if you didn't manage the risk appropriately. Dave, over to you now. I'll stop sharing my slides, Dave. If you want me to put yours, I can put yours. And yourself, Dave. Okay. I'm waiting for Dave to unmute himself while I'm stopping sharing. Okay. Stop presenting. Okay, Dave, if you can hear me, you are in mute. So yeah, that's it. We're gonna have a song about unmuting ourselves.
There we go. Unfortunately, when I put my screen up to share the presentation, I couldn't get access to my microphone. So there we go. I've learned something myself today. Right, can everybody see that?
Okay. I think it's coming up. I will mute myself. If there's any questions from what I've just said, pop them in the chat. We'll have a few minutes to talk about these things later on.
Okay, has that come up now?
Not yet. Not yet. I think it looks like it's loading up. From my end, I don't see anything. But I can load it from here if you wish.
I can see it, nice one. I can see the.
Okay,
yes, yeah.
Oh,
That's
okay.
fine.
Can everybody just give us a thumbs up if you can see it? Because I don't mind, because I've got it on mine. Thumbs up if you can see it. Okay. People can see Dave so far.
Okay, right. Okay. So forgive me, because while I've got it on my screen, I can't see any reactions. So it's nice and can sort of monitor anything. But like I said, we can cover any potential questions at the end. So as I said, while this was loading up, if you think about some of the things that that Nyson has mentioned about the management of risk, one of the heavier consequences of failing to manage risk is CQC's new powers that they were given for criminal enforcement. And I'd like you to bear in mind two of the aspects that Nyson mentioned in particular. One is about assessing and controlling that risk, and the other one is about recording it. Because part of my my previous role, although I was an inspection manager with CQC for a number of years and an enforcement lead, prior to joining CQC, I was a safeguarding adults coordinator with a local authority in the Northwest. And prior to that, I did 33.5 years with Lancashire Constabulary. The last 15 years of my time with the police was managing, working in and subsequently managing a public protection unit, dealing with child and adult abuse. I've managed several murder inquiries and high-profile criminal investigations, hence my role within CQC as an enforcement lead, and also managing a team towards the end of my time CQC, looking at some of the incidents which were potentially leading to criminal investigations and the obtaining of information to make those final decisions. So what I'd like to do really in this presentation is sort of give you a very, and it will be a brief, because if we were to go into it in any depth, you'd be talking at the very least, a full day on this to get the full spectrum of what can be done and what can't be done. But if I can give you a brief overview, and my main, while some of you may be providers and some of you may be registered managers, and I think as we discussed earlier on, there's someone still waiting to be registered. CQC tends to aim their criminal enforcement at registered persons. Now, a registered person can either be a registered provider or a registered manager. And there's a little bit of difference in so much as that a registered provider can be a limited company. And quite often limited companies have the resources of a limited company. They have the legal backup, they have insurance, they have all the things to protect them should they be subsequently prosecuted in the criminal courts. With a registered manager, I always find it slightly different, and having managed prosecutions against registered managers, and don't get me wrong, sometimes people do deserve it. Quite often the registered manager will get slung under the bus, and it's their own individual registration, therefore they are responsible personally, and they don't necessarily have all those protections such as the insurance and the legal backup without having to try and find their own. So I always used to feel a little bit, whether guilty is the right word, but certainly uncomfortable when it came to just prosecuting or looking at registered managers. So we're going to have a look at some of the basic stuff. Hopefully it will raise some of your awareness and summarize some of the things that CQC will be looking at. Now, prior to the current regulations, some of you have been around as long as I have, may remember that CQC used to work off outcomes, and there was 18 regulations under the old regulations, and CQC could prosecute criminally for any of those. But they had to issue a warning notice first, and I'm sure you're all aware of warning notices. You quite often see them in after a care home inspection. If there's any breaches of regulation and it reaches a certain level of enforcement, you could get issued with a warning notice. The warning notice itself was brought in with the old regulations, and if you think about when you get stops for speeding, or when you get if those of you who've ever had caught in a speed camera, you get a letter through that says you've been caught speeding, here's your notice of intended prosecution, answer the following questions or your consequences could be worse. essentially that's what a warning notice was. It was essentially a notice of intended prosecution, but 9 times out of 10 providers, registered managers, met the warning notice next time they were inspected, and CQC never prosecuted. In fact, it was very or extremely rare for CQC to prosecute anything criminally against any of the old regulations. So what are the differences? Well, the new regulations, when they came in, and we're talking about the Health and Social Care Act 2008 with the Regulated Activities Regulations 2014, which brought in the fundamental standards effectively. And they allow CQC to take action when they identify issues that were previously unable to take action against. As you well know, the fundamental standards are a bit more focused. And it enables CQC to remove or to move directly to if necessary, to a criminal prosecution without first serving a warning notice when those regulations are breached. If someone has suffered harm or been exposed to a significant risk of harm as a result of the breach of regulation. And there are certain criteria that CQC used, and the regulations I'm talking about are need for consent, Regulation 11, safe care and treatment, Regulation 12, safeguarding service users from abuse, which is your Regulation 13, meeting nutritional needs, which is 14. They can also look at duty of candour and display of ratings, which are also criminal offences, but I'm going to concentrate on the first ones I've mentioned, which essentially are 11, 12, 13 and 14. They all require a certain criteria, with the exception of Regulation 11. Okay, so the Regulation 11 is what we would call a bit like a fixed penalty for not displaying your ratings. Regulation 11 is what they call a direct offence. So if you fail at any stage as a registered provider or a registered manager, then to get valid consent of any person under your care, then in theory, CQC could prosecute you criminally for a breach of Regulation 11. And that can include simple things. If you think about, as we've been through the pandemic, and you think about the Mental Capacity Act, if you think about vaccinations, even something as simple as the flu jab, you know, people are allowed to consent to vaccinations or not consent to vaccinations. And if they can't consent or do not have the mental capacity to consent to such a thing, there should be a best interest decision and it should be recorded. If those things aren't done, CQC can prosecute directly. They only have to show that you haven't done it. The other regulations, 12, 13 and 14, they are with certain qualifications. So CQC can prosecute individuals and organisations. So these are in generally your registered persons. They can, on occasions, prosecute people who are not registered, but that tends to be mainly carrying on a regulated activity or a service that should be registered without registering. So at that point, they could prosecute somebody who isn't registered. However, for the purposes of Regulation 11, 12, 13 and 14, it tends to be registered persons. So going back to what I said initially, a registered person can either be a sole provider, a limited company, a partnership, but it could also be a registered manager. And when I say a registered manager, whilst it's a registered manager, it's your individual registration. If you have left that position, but an incident comes to light when you were the registered person or the registered manager, you are still in the firing line. So you need to bear that in mind. And that's why I think this type of information is crucial for registered managers in particular, because not a lot of people are aware of the powers that CQC have. Nominated individuals. Most large organisations have a nominated individual. Can CQC prosecute the nominated individual? Simple answer is generally not, because they are not normally a registered person. Whilst it can be a requirement of a registration to have a nominated individual themselves are not a registered person. So for the purposes of criminal prosecutions, and we are talking registered providers and registered persons, i.e. registered managers. So what happened when the new regulations came in was, previously the health and safety executive used to deal with investigations and prosecutions under the Health and Safety Act. When the new regulations came in, they saw a very big way out of some of the work that they had to do. They took a rather large baseball bat, and when it comes to service users, they batted them over the fence to CQC. So quite often, when you get your, well, as a registered provider, when you submit a RIDLAW in terms of an incident that's happened to the health and safety executive, if it involves a service user, the chances are that they will send it straight to CQC and it'll land on the desk of your CQC inspector. That's not to say that we don't work hand in hand with them, because we do. Quite often we share resources with health and safety executive. For example, if there was a large piece of equipment or a bed frame or whatever, call it what you want, that needed seizing as part of a criminal investigation, then the health and safety executive may assist us, because they have storage facilities, whereas at present CQC doesn't. Do we work with the police? Then yes, we do. We work particularly in the realms of deaths. CQC will work hand in hand under the work-related death protocol with the police. Quite often the word primacy comes to light in an investigation, and the word primacy is normally who is taking the lead on a particular investigation. So if you were talking about a breach of Regulation 12, safe care and treatment, it may also be a criminal offence if the act that's happened is willful. So the police would be taking the lead initially, working alongside CQC, and if at any point they decided it wasn't the high threshold for a police investigation, they would hand it then back to CQC, who would take primacy. That doesn't stop CQC or any other organisation doing their work in the background and carrying on their investigation. The only guidance we have with organisations like the police and the border agency is that we would ask them, if we are going to do X, Y, and Z, does that impinge on what they are doing, and does that affect their evidence gathering? But other than that, the investigations can work side by side. CQC also works alongside local authority safeguarding teams, and also we have good relationships with Companies House. For example, if we were taking a criminal action or investigating a particular limited company, we can have markers placed, or CQC can have markers placed. I keep saying the royal we. I only retired in March, so it's still got the royal we. CQC can actually have markers set on Companies House and on their register to show an alert if something suddenly changes with that particular company that they're looking at. CQC generally don't have separate teams. Whilst I said at the beginning I did run a team looking at criminal investigations, in the main that was because there had been a backlog. And I think the one thing that, as registered persons, that you do have to your advantage is that the majority of CQC inspectors, whilst they may be very good inspectors and know what they're doing in terms of looking at regulations and inspecting care homes and domiciliary care agencies and hospitals, dental practice, you name it, they're not police officers, and they weren't initially trained to do criminal investigations. And quite often, some incidents that happen get missed, and there becomes a backlog of incidents that have to be looked at. Hence the team that I was running before I retired. Sharing of information, yes, we do share information with all the relevant key agencies, such as the police, local authority, coroners is another one that we share information with, and quite often a coroner will delay an inquest if they are aware that CQC are carrying out an investigation. So what powers does CQC have, or in terms of their enforcement, if you actually breach any of the criminal offences? Well, like with most criminal offences, if there's an admission of guilt, they can issue what they call a simple caution. They can issue a fixed penalty notice, which is a bit like your parking tickets. If you park your car on a double yellow line, you get a fixed penalty notice. If you breach some of CQC's criminal offences, and in the main we're talking about, so for example, a simple one would be fail to display your rating. It's a criminal offence. They can issue a fixed penalty. What CQC do say is, though, that if the party was to challenge that fixed penalty notice, they must have sufficient evidence to take it to court. So they would still get sufficient evidence to prove that offence in a criminal court, even though it may well have been issued as a fixed penalty. And the final one is a criminal prosecution, and that is through the criminal courts. This is not CQC's normal civil regulations, the regulatory requirements, the warning notices, the notice of proposal, notice of decision, and so on through to the first-tier tribunal if you were to appeal of it. This is a criminal prosecution through the criminal courts and using the full weight of the criminal law against either a registered provider or a registered manager. And there have been quite a few in the last couple of years. It took a while to build up. Anyone from the Northwest may have seen one recently. There was certainly a registered provider and registered manager who happened to be the same people for that particular home in a home in Lytham. And I think it was the fine was around about the £100,000 mark for failing to provide safe care and treatment. So these convictions, these prosecutions and investigations are taking place, and even more so is the rationale why I think you need to know a little bit more about this type of stuff. So thinking back to what Nyson said, what happens when an incident happens in a care home? Well, first of all, the CQC inspector will carry out what they call an initial assessment of the incident. Now, this isn't a prosecution. This isn't necessarily evidence gathering at this stage. It's basically looking at the incident and seeing whether someone has suffered harm or have they been exposed to a significant risk of harm, and putting it in a nutshell, could it have been avoided? So if you think about the risk Nyson was talking about before, Mr. X comes into your care home, no previous history of falls, as far as we know, steady on his feet. You move your care plan around him. You've got everything in place for that for Mr. X, and he's doing fine. Then all of a sudden he has a fall. Is that something that could have been avoided in terms of CQC's criminal powers? Possibly, but I would argue no, because no previous history, you've nothing to work off, and therefore you probably wouldn't get looked at as part of an initial assessment. If they deem that as part of that initial assessment that there might just be something to look at there, and the information could come in initially, I mean, from a notification. I mentioned RIDORs before, which get passed on to CQC, but also as a registered provider, registered manager, you submit notifications on a regular basis about injuries, deaths, incidents involving the police. There's a whole range of notifications that you submit to CQC, all of which could trigger, and quite often do trigger, what they call an initial assessment. If they feel that there is more needed, they have got evidence gathering powers and policies and procedures around gathering evidence. And on tap, they can request legal advice and decision making. Generally speaking, an inspector on their own can carry out an initial assessment and close an incident down. But if it requires a meeting or management review meeting, generally the discussion will be between the inspector and their inspection manager initially. So what they're looking for and the questions that they ask as part of an initial assessment, and if you think about that example I gave you before about someone coming in with no previous history. So does the information about the specific incident raise concerns about the risk of ongoing harm to service users? And should CQC inspect? That's the first question the inspector asks themselves. We've got this incident, it's happened, somebody's been injured, but looking at the circumstances of it, are there other service users within that environment or in that home or in that domicile? Is there anybody else at risk, and do we need to inspect? Now, if they go out and inspect, that isn't necessarily part of the criminal investigation. There is a risk of harm, so they're going out and it triggers a normal, what CQC would call a normal compliance inspection. They could just go out and gather evidence. Now, if they go out and gather evidence, it doesn't need any announcement. They can just turn up and look at records. They can seize records. They don't actually have to do a report about their visit, but they are only looking at stuff around that specific incident. Whereas if they come out and inspect because of an incident that's happened, so if it's as a result of someone having a fall or fracturing the hip or whatever, they would look at the risk of falls across the service, other service users' care records as well. Whereas if they come out to look at just the evidence, the chances are they'll just be looking at the evidence around that particular person who's suffered harm. The second question they're asking themselves is, does the information about that incident that we've been told about, was it avoidable and may have resulted from a breach of a prosecutable fundamental standard? So if you remember, going back to what I said previously, regulations 11, 12, 13 and 14 are prosecutable with certain criteria. And that's what they're looking at. And one of the main things they're looking at was that harm avoidable? And if so, should we gather further evidence about the incident to support potential criminal enforcement? Okay, so there's the two strands. And the two strands can work hand in hand. And it's so important that as registered persons that you are familiar with the elements of the offence and what they're looking at. So CQC basically under it's regulation 22 of the regulations that gives CQC this power and sets the criteria. So if CQC are looking at a breach of regulation 12, safe care and treatment, because someone's had a serious injury, you'll be looking at the elements of regulation 12, and they have to fit the criteria of regulation 22. So CQC have to prove beyond a reasonable doubt, which is the criminal standard, a registered person failed to provide safe care and treatment resulting in harm, significant risk of avoidable harm. That's what they are looking at. And if CQC can prove that, the balance or the burden then passes to the defence or you to defend yourself. And the one thing that you do have in your favour is that whilst you've only got one statutory defence, the burden of proof for that defence is different. So CQC have to prove to the criminal standard, i.e. beyond a reasonable doubt, which is exactly the same as someone being prosecuted for theft, burglary, murder, infanticide. It's that criminal proof. But any defence you have is to the civil standard, i.e. on a reasonable balance of probabilities, that you took all reasonable steps and exercised all due diligence to ensure safe care and treatment was provided. So if you think back again to what Nyson was telling you about assessing a risk, controlling that risk, and in particular, if you think about your defence there, recording it, because if it isn't recorded, a lot of occasions, if it's not recorded, you haven't done it. That pretty much goes a long way to sort of standing up for your defence. And when CQC, when the inspectors are looking at their side of things in terms of can they prove beyond a reasonable doubt, they would be stupid if they didn't take into account that particular defence and have a look at whether you'd taken all reasonable steps at the same time. Because if it's obvious that you have, then there's no point in them proceeding it or prosecuting it any further. So that bit that Nyson mentioned to you about managing the risk is absolutely crucial in terms of CQC's criminal power. Because if you can show, so if we go back to Mr. X again, that came into your care home, that actually this guy came in with no past history of falls. We spoke to the relatives, we sat and had a chat with him. There was no evidence, or nothing to show whatsoever that he was likely to have a fall. He had a fall and we did everything we could. Further down the line, if Mr. X had another fall, then you need to start thinking, well, actually, he's had one previously. That's when you start to look at that risk and start to say to yourself, actually, what can we do to prevent him falling in future? And that's when that recording and assessing the risk that Nyson was talking about before comes in. So as I said, most initial assessments are carried out by the inspector in consultation with their inspection manager. And if you think about your notifications and a lot of the questions that are asked on a notification, or if you submit a notification and they come back to you saying, can you just tell us X, Y, and Z? A lot of it is in relation to this initial assessment that they are carrying out. CQC doesn't have any incident selection criteria. They don't pick on certain ones at a certain height. Each case is assessed on its own merits. Incidents that are more likely to go for investigation or to pass an initial assessment are things like falls from equipment such as slings and hoists, faulty equipment, baths, bariatric chairs, falls from height or a bed. Medication errors in particular are quite a big one. Serious burns, water, radiators, heaters, pipes. I can think of a number of prosecutions that CQC did take forward where people have burnt themselves on radiators in particular, where radiators haven't been covered or hot water pipes haven't been covered and someone's fallen out of bed, burnt their arm, serious burn on their arm against a hot pipe. Could it have been prevented? Yeah, you've got to say possibly could have been prevented, probably should have been prevented. That's where they'll be looking at how that risk was identified and what was done about it, if that makes sense. Choking is another one where the risk has previously been identified. Entrapment, in bed rails, one of the ones at the care home at Lytham that's recently been prosecuted was an entrapment in bed rails, which was quite where the poor service user actually virtually hanged themselves with the bed rails. Ligature deaths, particularly in mental health facilities, in hospitals, certain what they call never events. Those are more likely to go for investigation. Those that are most likely to get closed at an early stage at the initial assessment are things like falls when mobilizing in communal areas, medication error where no actual harm or there was limited harm, choking or falls where the risk was unforeseeable. So I've got, going back to my Mr. X scenario. Cases where it's low-level harm, bruising, not requiring stitching, can't establish clearly serious harm arose from it, and cases where the primary cause of harm or risk arose from an individual error. Now, individual error is quite a big one that gets looked at, and that is because if you think back to what I said initially about who can CQC prosecute, if as a registered person, you have put everything in place. So for example, I can think of one particular one that I looked at, care home over on East Lancs, where a service user was being hoisted into a bath. The service user was hoisted by one care worker. So the straps weren't secured. The service user fell out of the chair and cracked the head on the tiled floor. from the registered provider's point of view, the staff had all had training in moving and handling. They'd had training on that piece of equipment and knew how to use it. And in fact, in that particular case, there were signs all around the bathroom saying, do not use this equipment on your own. Always make sure 2 members of staff are present, whatever. Quite clearly, those members of staff had gone against those instructions. Yes, the fall, you could argue the fall was preventable, but was it the fault of a registered person? The answer to that would be no. That would not get through the initial assessment stage and it would be closed. So you can see quite clearly where it is important that as a registered person or registered manager, that you have made sure that those risks are assessed. And if you're not doing it personally, you've got oversight of it, you make sure those risks are assessed and what you've done is recorded. Because if a member of staff goes against those instructions and somebody gets seriously injured, it's not you in the firing line. And that's the important point to remember. So you do need to remember that a CQC prosecution can have serious consequences for a registered provider or a person's professional reputation and ability to deliver care in that sector. Is anybody going to ever employ you again if you've had a prosecution against you for causing serious harm? Chances are not. What is a criminal investigation? I mean, a criminal investigation isn't necessarily a prosecution in itself. It can result in a prosecution, that goes without saying, but it's an investigation to try and establish whether an offence has been committed in the first place and or who has committed it. So just because it goes through an initial assessment and CQC do start to investigate, an investigation isn't a prosecution, because the outcome of an investigation, having gathered all the evidence which CQC can gather by means of letters, they can make requests to you as registered persons. If they don't get it easily, they can issue Section 64 notices to compel you to provide that evidence. They can use PACE interviews, Police and Criminal Evidence Act interviews, which can either be by letter or can be taped and recorded in an interview room. But at the end of the day, that investigation, the whole outcome, the whole point of an investigation is to establish whether an offence has been committed and has somebody who has committed it. It may well be that the outcome is that actually no, an offence hasn't been committed and actually that person hasn't committed it. It could have been individual error, as I said, a member of staff. But that is a very quick fly through, and I think we've just about got to the hour there, haven't we?
Yeah, I was going to say
it's amazing how quickly it goes through. But that is an extremely quick fly through of some of the stuff that CQC look at criminally. As I tried to explain, it's a minefield and a full. You could literally spend a day going through the finite detail of it. But my main thing is to highlight the awareness to yourselves as registered persons and in particular registered managers, because you are vulnerable under your own registration without necessarily the backup of a limited company, to be aware of these things. And if there's anything we can do in the future, or any of you want to make contacts with us separately, or if you want some training for your registered managers or your staff, then feel free. But I do think it's a particularly important part of the regulator's powers that aren't always obvious to people when you first register. It may well be that some of you were fully aware of all this and are fully au fait with it. But from my past experience as an inspection manager, I would say a good 80% of registered providers, or in particular registered managers, weren't aware of the risks they were under in terms of CQC's criminal powers. So I hope it's been useful for you. Back to you, Nathan.
Oh, thank you very much, Dave. Thank you. No, that's fab. It goes so quick, but there is a lot that you can go through there. I mean, risk management itself is a whole day thing that you can do. risk monitoring, auditing risks. It could cover just one area of risk, which is fall, half a day to cover falls on its own or equipment. So it's quite a long thing. I know we've overrun, but is there, do people have any questions or anything that you want Dave to answer? You can unmute yourselves now.
I suppose the first question I've got is, the only question I've got is, has it been useful for everybody, for anyone? Or have you learnt anything that you didn't already know? Oh, that's good. I can see some thumbs up. Yeah, good. I'm glad about that.
Yeah,
I am glad. I mean, I'm conscious it was a very brief run through, but it had to be, because you couldn't do the full, lot. Certainly on the criminal stuff, you couldn't do it in an hour. And I apologise if it seemed a bit fast, but there is a lot more to it. But it is so important that you're aware of these things.
Yeah, and it's also to understand that you and your staff, what you are required to do is to understand who is at risk in your home. At the very basic, I think when inspectors walk into your care home, you have to have an idea of what risk are you carrying. That's the start. So that initial conversation when inspectors come in and sit down with you and say, oh, we're introducing the inspection, we're here to do A and B and C, whether it's a responsive inspection or an ad hoc inspection. The idea that they're trying to get out of you there, those initial stages is, how do you know what risk you're carrying? So they'll be asking you, how many people do you have with this type of needs, or how many people have you? That the idea is to actually test out, do you understand what risk you're carrying, who's at what risk? Then obviously to lead inspectors into who are they going to pathway track. It could be that they already have an idea from the notifications that you've been submitting. They know who is at risk. But majority of the time, if you fail then to say, oh, John Smith is at risk of falls, and the inspector knows that they've received 15 notifications about John Smith, and you can't actually say, oh, the one person who's falling a lot is John Smith, that starts to ring bells for inspectors there. So it's just having that awareness that you need to know what you're carrying within the service.
Yeah.
Okay.
Like I said, CQC get their information from various sources. I mean, the main one is the notifications that you submit. So every single notification that you submit to CQC get, in relation to an injury, will get looked at. And the first thing an inspector should be thinking, and as I said, at the end of the day, they're not all ex-police officers, but the first thing that they should be thinking is, yep, this person suffered harm. Was that harm avoidable? Do I need to get any further information? And then at some point, do I need to have an initial assessment about this? It could be that the information has come from the police. It quite often an assault or an assault by one resident on another can get reported to the police before it gets reported to CQC. The police then contact CQC and say, we've just had this incident reported to us. We don't think it's in our remit, but actually it could be in your remit. So that's another source. Coroners, if they hold inquests, quite often might ask CQC, I've got these details of this person's death that I'm holding an inquest into. Is this something that you might need to look at? So there's all sorts of ways that this information comes into the regulator. But as I say, it's just, if you think of the basics, it's about covering your own back and making sure that if something does go wrong, that if you think about that statutory defence, if nothing else, the fact that you have taken all reasonable steps to prevent that harm, and that goes back to your risk management that Nyson was talking about, and you're not going to, to a degree, you're going to protect yourselves from that type of criminal prosecution. So,
Thank you, Dave. Thank you. So if you want to hear more, I mean, you can contact Dave if there's more you need to know and around enforcement in particular, and how to support yourselves, including safeguarding really and MCA. I think Dave, you've been leading those areas for quite a long time during your time at CQC, isn't it? So
Yeah.
MCA enforcement. You were the MCA lead for the Northwest, isn't it? For the North.
Yeah, that's one of my others. When I worked for the local authority as a safeguarding adults coordinator, I also managed to had oversight of the DOLS process for the local authority and for the then PCT as it was, because the local authority used to do the DOLS for the PCT at the time. I know PCTs have since gone and have now went to CCGs, and now CCGs have gone to local area health boards, etc., etc. So yeah, MCA and DOLS is another area, and of course it links in with Regulation 11, which is one of the things that CQC can prosecute for.
Yeah, direct offences.
Two hands up there.
Yeah, we've got two hands. Nicole, if you want to go, then Harry, you can come in.
David, so I just wanted to ask regarding the best best interest assessment.
Mm-hmm.
Is that on? I mean, for a dom care agency, what role would a domiciliary care agency play apart from maybe supporting the assessor?
Well, for a domiciliary care agency, there are certain things in terms of someone who lacks capacity that you would want your carers to be doing for a start of a 10, like, you know, having regard to the person's wishes, the way they want their medication administered, the way they want bathing, the type of carers they have. In terms of DOLS, as we all, until the liberty protection safeguards come in, in terms of DOLS, if you feel that the care that you are providing is to a restrictive state that you think it would, under normal circumstances, it would be a DOL, then obviously your role as a domiciliary care provider is to approach the local authority and say, we think this is restrictive practice. We would like you to apply to the Court of Protection for a DOL. You wouldn't, as it stands at the moment, as a domiciliary care provider, you wouldn't apply for a DOLS yourself. It's about having those systems and processes in place, and that's what the inspectors would look at. That you've got those systems in place that if you identify a particular restrictive practice through the care that your carers are providing, that you've got the ability to contact the local authority and say, we think, you know, it's not up to you to make that decision, but we feel this practice is restrictive. We would like you to take this to the Court of Protection to apply for a DOL.
So would you be suggesting, because I mean, I do best interest assessment and DOLS, but for dom care, in terms of the legal framework, I had to ask myself in terms of, because obviously if a client wants care and support within the home, it will be more around the recording and highlighting that to, like you've mentioned, maybe the local authority, but it won't be for the domiciliary care agencies to take it on, because that question was asked, and you know, I had a little bit of a hiccup when I was asked in terms of, oh, how will you do X, Y, Z? So from my experience, if it was a residential home, yes, some will be trained in a residential setting, but with a dom care, it's not all the time that you're going to have a qualified champion who will do the mental capacity assessments.
No, that's right. And a lot
can I answer that one, Dave?
Yeah, by all means, nice.
Yes, So there's two things you're talking about there. We just need to make sure we separate them. Undertaking a mental capacity assessment for someone who's living in their own home so that you can provide them with care as a domiciliary care provider is your job. You are the care provider, okay? What you need to understand there is when you are providing care to someone, the idea of consent in MCA is I am drawing a care plan here so that my staff will provide you with this care. Do you agree with this care? That's the decision you're asking that person to make. That's the difference. Yeah. So it's your role as the caregiver. I always give this example to providers when I used to work within the sector. I used to say to people, if you're going to hospital, okay, you're going for a surgery, say for example for amputation, who signs the consent, who does the MCA for that amputation? Is it your district nurse who is in the community, or is it the surgeon who's holding the knife and the scalpel? The answer is the person who's giving care at that particular time is seeking your consent, which is the surgeon. So that's for you as a provider. If you're working with someone in the community, in their home, and you want to seek consent about, your staff have to be MCA qualified, MCA trained. They need to undertake MCA for that particular part of care to see whether the person agrees to the care plan. That's your job as a provider. So you have to do that.
But there are obviously some, while your care staff are providing care, there's daily things that they will be doing that you don't necessarily need to, you know, I mean, I've seen recordings, you know, provided breakfast to Mrs. Smith. She preferred to have cornflakes rather than wheat. It's an MCA decision, isn't it? You know, she's given consent. It's a very basic one, but it's the type of stuff that happens every day. But as Nyson said, the main thing as a domiciliary care provider or registered manager is it's that consent to providing the overall care plan that service user has, because quite often the local authority will provide you with an assessment and their view of what the care plan should be. But then you have to do your own, don't rely on the local authorities, is my advice. I would say always write your own care plan based on the local authorities and get permission from that service user to provide that care that you've got in the care plan. And obviously if they haven't got the capacity to make that decision or agree to that care, that's when your best interest decision and potentially your discussions with relatives and people who have been involved with that service user would come in, and you would record that best interest meeting as part of that consent in a way to the care plan. Does that make sense?
Yeah, I think the reason why I ask, because it's very technical. When you're doing dom care, you will have private clients and you will have those who are referred by the local authority. So obviously, when you go in, you must always presume that they have capacity unless proven otherwise.
Yes, absolutely.
You understand? So where I'm coming from is more around, as a dom care agency, our legal responsibility will be to record and notify the place, the kind of like if it's through the local authority, would a dom care lead a best interest assessment without the social worker? Because unless it's a private client, so that's where I'm trying to. So if it was a private client,
so they won't. Yeah, so you can't lead a best interest assessment anyway. You can't.
That's the key part I wanted to.
No, you can't. It's chaired by, say, if they're funded by the local authority, even if they are not, they have that responsibility. But in terms of, as a provider, as a caregiver, you have to do an assess. It might be technical, but that's the whole idea why it's complicated. Regulation 11 of the HCA requires you to undertake to seek consent. The only way you can do that, if you have any doubt that someone is not able to make a decision, the first principle is you presume that everybody's got capacity. But if you've got any doubt, if there's any reason to suggest that that person may lack capacity, you need to undertake an assessment. So regardless of you being a DCA, you have to do that assessment, which leads you in different other routes, you know, if that person can make that decision. But we can have this discussion. If you want to, you can contact me or Dave. We can discuss about it in detail, really. But don't get caught offside. You need to do, for anybody, it could be private, it could be local authority funded. As long as there's any reason for you to undertake, to doubt their capacity, their ability to make a specific decision, you need to do. Don't say it will be the social workers or it's the GP, which is the answers that we used to hear. Is yourself caregiver. Harry, I know you've been waiting. Where is he gone? Harry. Do you want?
Yes, this conversation is quite clear for me, because my question was related to that as well. Like, because I'm managing 4 residential care setting now, so I have gone from nursing to a residential like a environment. So I was having the same kind of concepts, like if someone has capacity, even like they fluctuates in few other areas, so how those areas can be consent, or how those best interest decision can be made. So my questions was related to that, but this kind of conversation which gives me the idea how to get the best interest assessment to be completed and MCAs to be completed. So I'm all right now. Thank you.
Okay.
No, that's fine. Yes. So as long as you can doubt that there's a reason why you think someone's capacity may be impacted, then you need to. But the presumption is that everybody's got capacity, unless you can prove, or unless you've got doubt.
Yeah, and it is a minefield. I mean, yeah, the mental capacity came in what 20 odd. How long is it now?
2005.
Came into implementation in 2006. There's still people now that don't understand it. There's so many grey areas in the Mental Capacity Act. It's hopefully when liberty protection safeguards eventually come in, Lord knows when that'll be, it'll be a little bit clearer in some aspects. And of course that then will make a difference for the likes of yourself, Nicole, because it'll involve domiciliary care agencies and home care being able to do their own DOLS assessments as opposed to the local authority. So it'll be even more of a minefield.
Yeah.
Indeed.
Thank you very much.
I just wanted to touch in, if a submission is to be made in court, so will it be the agency that does the application, or for LPS?
No, it would be the local authority.
Okay. The local authority. Yeah. No, that's fine. No, that gives us a flavor. Maybe next time we can have a chat around. We can just focus on MCA and consent. It's an area that I like. Dave focused on that. I was a lead on that. Dave was a lead on that. I eat and breathe MCA. If I'm being honest, I like it. I just like it. So we can have that at some stage. But thank you very much, everyone, for coming. Hopefully you enjoyed the session. If anybody needs to contact us, we are on LinkedIn. Dave is on LinkedIn. I'm on LinkedIn. We can always have chats and conversations. If you need any of our services, by all means, email us or catch us up on LinkedIn. Share with other people as well. I will share the slides with you, the recording for this. Share with other people, by all means. If we can improve practice in one area, then that's one service user and one registered manager who's been saved from prosecution.
Yeah, and that's sort of my goal really, is to protect registered, not registered providers as well. I'm not having a downer on registered providers, but generally speaking, registered managers are out there or get left out there on their own. So we can help any registered managers to protect themselves. That's my big aim, because I never really felt comfortable with that side of it.
Thank you, Dave. Thank you very much. Thank you, everyone. All the best. Yeah.
Thank you, Dave. Thank you, Nathan. I appreciate that.
Okay,
thank you.
Thank you.
You're welcome. Thank you. Thanks for your time.